profound connection with what nursing can do.
How nurses becoming entrepreneurs in managing their own practice and providing the leadership.
These are powerful women.
You also develop the social care and really looking after the whole community in a very integrated, supportive way.
Japan's aging population. But guess what? Now the Western world's catching up and they don't talk about it so much.
I hope not only Japanese nurses, but also global nurses can make very close communication.皆様こんにちは。笹川保健財団の会長の北悦子でございます。本日 Nursing Now フォーラム in Japan を、共催させていただけることを大変光栄に存じております。私は、もともと小児科医なんですが、病院で勤務をした後、国際保健で、たくさんの、途上国で勤務させていただきました。その後、日本赤十字社特に九州国際看護大学で教職を取り、その後現在の笹川保健財団に移っておりますが、最初の病院時代から仕事のそばには看護師がいたわけですけれども、特にその次の国際保健の現場では医師がいない、病院がないというところで看護師さんが働いておられることで看護の力に気がつきました。そしてその後日本に帰ってきて看護教育に携わった理由は、日本の看護師の優れた力があまり海外では分かっていない、評価される以前に見えていないということから、ぜひ日本の看護を海外に発信したいという気持ちを強く持っていました。そのようなことで、本日のこのナーシングナウに関与させていただけることを大変光栄に存じております。よろしくお願いいたします。本日の開催に対して私どもの事業、笹川保健財団がやっております看護師が社会を変えるという大相談タイトルですけれども、それについてなぜこういうことを始めたのかということを少しお話しさせていただきたいと思います。日本は人口が増えて経済発展した時代から超高齢化、少子化、そして経済停滞の時代に入っております。保険医療経費は増大する一方であり、国民皆保険という非常に優れた制度をどうやって維持するのかが難しくなってきております。合わせて疾病構造は変化しており、治療可能な病気を医療施設で治療するという時代から、生活の場で予防すべきいわゆるノンコミュニカブルディジーズが優位になった時代に入ってきております。つまり、キュアの時代からケアの時代、医療施設から地域へという流れが必要になってきております。そのためには住民や病院、あるいは人々の意識を変えていく必要があると思います。そこに看護師の力が必要だと私は思っています。日本の在宅訪問看護の歴史を見てみますと、実は1888年という古い時代に発出看護協会というのができているんですけれども、実際にはそれほど増えていないということが分かります。こうやって見てみますと、在宅訪問看護の制度化、体系化はまだ途上であるということが言えると思います。近年、訪問看護ステーションが増えてまいりましたし、複合型サービスあるいは、特に看護小規模多機能企画型事業、私どもはカンタキという言葉をそのまま英語にしておりますけれども、そういうものが出てきたというのは大変いいことだと思っています。しかしながら実際に訪問看護、在宅看護に従事してくださる看護師さんの実態を見てみますと、実に少ない。 日本全体の看護師総数が約140万人ぐらいいらっしゃる中で 3.5%、本当に微々たるものであります。とは言いながら、グラフで見ますと、ここ数年間、10年ぐらいの間にかなり事業所が増えてきていることは事実でございます。この中でですね、訪問看護に従事してくださる方の育成が大事だろうと思って始めたのが今の事業です。はい。私どもの目指しております事業の骨格でございます。地域の中にですね、日本財団在宅看護センターという、看護師の城と私は言っておりますけれども、それを作って地域のいろいろな保健資源と連携をしたいと思っております。同時にですね、スライドの右の方でございますけど、在宅看護のエビデンスというものを作って蓄積していきたいということと、左側に書いてございます地域住民の活動を支え、地域を強化することが大事だと思っています。看護師による社会的処方というものを私どもは実践したいと思っておりますが、はい、いずれにしましてもこのセンターというのは看護師の城でございまして、看護師がここにいて地域のあらゆる保健医療専門家と連携をする、そういう役割を担えるところを目指しております。現在25都道府県において74カ所のセンターが稼働しております。ちなみに2020年度の研修生を入れますと、全体として110人が研修を受けられております。また74人開業なさっていますけれども、事業所としてはいろいろがありまして、今84箇所動いております。これが来年には100箇所を超えるだろうというふうに思っております。で、先ほど申しました在宅看護のエビデンスを集め、地域の人々の意識を変えて地域のプライマリーヘルスケアの中核を作っていきたいというふうに考えております。ここから後のところはこの事業の1期生であります金谷さんに司会をお願いいたしたいと思っております。金谷さん、よろしくお願いいたします。
今ご紹介に預かりました一般社団法人方面のオーナーであり管理者である金谷マスコです。よろしくお願いいたします。私は神奈川県で、の伊勢原で2007年に訪問看護ステーションを開業しまして、今年で13年目になります。13年目でサテライトを含めて4カ所の事業所、それから2カ所の居宅介護支援事業所、そして、今年の3月1日に開所しました神滝の方面の里の運営をしています。世界的なフォーラムのこの司会者になるということで感謝しております。よろしくお願いいたします。ここでは3人の外国人エキスパートと私たちの仲間の発表を行います。最初の発表は ICN 前会長、ジュディス・チャミアン先生です。ご承知のことですが、ICN は世界130カ国以上の看護団体が加盟し、2700万人を超える看護師を代表する組織です。シャミアン先生は2013年から2017年までの会長を務めました。また、シャミアン先生はカナダで120年の歴史を持つ地域医療の大手 NPO VON の元会長でもあります。VON は6400人の従業員と6200人のボランティアスタッフからなり、在宅看護ケアに関して先駆的な取り組みを実施しています。今日はグローバルな視点から看護師に求められる役割についてお話しいただきます。
Ladies and gentlemen, I am Judy Chamian, the immediate past president of the International Council of Nurses, and I am delighted to be with you through technology. I wish I could be with you in person. I cherish my visits to Japan and spend time with the Nippon Foundation, to my colleagues with Dr. Kita, with the Japanese Nursing Association, which is an amazing member of ICN, the Ministry of Health, and the nurses in Japan. I want to bring you greetings and congratulate you for hosting and launching Nursing Now. You joining hundreds of other organizations that have taken on the Nursing Now challenge and have done great things in advancing the health and nursing in their countries. So congratulations and have a very productive day. And I do hope that soon enough I can meet you all in person. All the best. Good morning, everyone. I am delighted to join you and give you a presentation on the Year of the Nurse and the Global Health Agenda, and talk about the role of nursing and the role of home care, which is very important given the current reality. The State of the World Nursing Report was released April 7th. It's a massive document that each and every one of us should become somewhat familiar with. It's the first ever snapshot of data about the global nursing workforce. The State of the Nursing, the World Nursing Report has 10 key actions, and I'm not going to go through all of it, but if you see some of it, we say it talks about shortage of countries will need to invest in nurse education and employment, monitor and ethically manage nurse migration, which is not such a big deal in Japan. Nursing leadership and governance are critical to strengthen nursing workforce. Countries should plan for a gender-sensitive nursing workforce. This is a big one in number 2, to strengthen capacity for data collection and analysis. We don't know enough about those things. And number 10 is something that you actually exercising now. Collaboration is the key. To move forward the health of the people and nursing care, whether it's in the hospital, home, community, like you have in your Kentucky centers, is collaboration. Let me turn now and talk for a couple of minutes about the global agenda. What are the big things that the world is worried about, in addition to COVID-19, which it seems to take up most of the energy at this point? But we cannot forget all the other issues that we have to deal with. Universal health coverage, which means that every single person in this world should have access to healthcare. And we see it more than ever now that we're talking about mass immunization. How are we going to get to those remote areas, and how are we going to give it to people who are underserved and have challenges? When I was in Japan for the Mahidol conference, the last one that was held, I went out to visit some communities where nurses led incredible community programming and community efforts. So we need to understand how we're going to deliver universal health coverage. And in many countries, it's a real issue. The Sustainable Development Goals, which I will get to in a minute, is another issue. How are we going to make sure that we will achieve the 17 targets that are set out, that includes health, poverty, education, gender issues, and we need to have a clear agenda of how that will happen. Non-communicable disease is a huge issue. There is a report that came out from OECD last week, and I looked at the information as it relates to Japan. So for example, you have challenges with lung cancer stomach cancer, breast cancer, and so on. You have less of a cardiac issues. And then what really reminded me some of your non-communicable diseases and not chronic diseases is your rates of injury and death. And your rate of death is very high, and it's mostly related, I think, to self-inflicted, basically suicide. And I think some of the efforts of what's going on in different countries when it relates to injury and so on needs to be dealt with. Human resources for health is another major issue across the world, and you've seen just in nursing alone, we are short of millions of nurses, but we also have problem of where those nurses work. Many of them work in cities and don't work in rural areas. Aging is also an issue, and interestingly enough, this OECD report said that in Japan, if you reach the age of 65 and you are a man, you're likely to live until the age of 89. And if you are a woman, you're likely to live until age 95. And hopefully, you live those years as healthy. And a lot of it depends on home care and community care and social support, because none of us, whether we are 80 or 90, want to spend the rest of our life in hospitals or other settings. We need to strengthen the health system, and we need to worry about man-made disasters and other disasters, and you are very familiar about earthquakes and others, and of course pandemics that I don't think today we need to talk about because we're all familiar with. So this is the Sustainable Development Goals, and I hope you are all familiar with it, because we could spend a whole course just talking about the SDGs. And these are goals, and there are many, many of them under each one of the 17 categories that needs to be met by 2030. I have to say, we have to pay special attention and make sure that we are integrated in moving forward. And of course, a lot of discussion is about goal number 3, because it's about health, but there is no health when there is hunger or poverty, or there is no gender equality, or there is no clean water. Dr. Tedros said, nurses are the heart of most health teams, playing a crucial role in health promotion, disease prevention, and treatments. As health professionals who are closest to the community, they have a particular role in developing a new model of community-based care and supporting local efforts to promote health and prevent disease. And Florence Nightingale said in 1870, hospitals are only an intermediate stage of civilization, never intended to take in the whole sick population. May we hope that the day will come that every sick person will have the opportunity to share in a district sick nurse at home. And what Dr. Tedros said in 2019 and what Florence Nightingale said in 1870 is what Dr. Kita, the Nippon Foundation, the nurses that are part of the this direction are you doing, and providing incredible example globally. You do it locally, but what you're doing needs to be spread globally, because what you're doing is an exemplar of how we can move home care and social care forward. So I hope you take a lot of pride in what you're doing. So now we're getting to the second part of the presentation, which talks about what is community and home-based healthcare. But there are major trends that affecting home care that needs to be kept in mind and keep moving the policies at the government level and the programming in the district level, and so on. The population is aging, and Japan again has a perfect example, and I think you had the largest number of people who live to be 100 and older in the world because of your system. There is a growing number of chronic diseases, changing family structures. There are many countries and many places where the families don't live together, so seniors or aging population lives alone and they need support. Cost effectiveness, new technologies, which is really essential, and nursing workforce crisis. So we need to understand that all these 6 trends affecting home care and contribute to developing and making sure that we keep moving with building a strong and developed home care. The home care team composed of many different people. First and most, it composes the person who needs home care. And very often, the people who are at home, and when they are alone, they deliver a lot of the care for themselves if they are able to. Then there are family caregivers. And there are many studies that show that family caregivers are a very unique group of people, and oftentimes they are also get sick, they need support, their mental health needs support. It's quite a difficult undertaking, but family caregivers deliver a lot of the home care. Of course, nurses who are there to assess, advise, teach, support, and care. And then health and social welfare personnel. When I was the president of the Victorian Order of Nurses, every day we delivered over 9,000 meals to people who lived alone who couldn't cook. But if you don't have food, all the best nurses in the world and all the best family caregivers, you're not going to be able to manage because you need your nutrition and nutrients. Community health workers and community volunteers. And I can't say enough about the importance of community volunteers. And those are usually people who know you from the community or from the church or from other places, and they understand your culture and able to be supported. What are some of the future directions of home care nursing? We need sufficient resource allocation, elaborated policies on roles and responsibilities, efficiency of outreach program, and creating new opportunities for nurses. And one other thing I would enter here, evolving technology. We need to respond to emergency situation, specialization to home care and community nursing, like you do it. It's not enough to say, I am a nurse. Home care and community nursing is a specialty, just like critical care is a specialty, like cardiac nursing is a specialty. We need to support for self-care so people can look after their own health and be independent, whether if they have diabetes or other problems. We need to strengthen the community system so they can support home care, promoting well-being overall. The Canadian system is good to understand, but it's not spread across the country equally. Our national healthcare law does not include home care. So home care is different everywhere. Each province has a different funding element for home care. Private and out-of-pocket and public spending is around 6% of total healthcare spending. And we rely heavily on unpaid workers, both family and volunteers. So we don't have enough paid healthcare workers to do home care. And we know that 1 in 10 people provided some supportive care to somebody at some point. So when I had my knee surgery, I had my children, I was in the hospital only 24 hours. but my family, my daughters who don't live in Canada, came to take care of me. Okay? So the notion of supportive care is alive and well because it's needed and the system doesn't provide enough care. I came to the end of my presentation. I think what we need to realize that the role of nursing in home and community care is very important. Nurses need to be in policy advisor position, community partners, industry partners, especially as we look at technology development, system leaders, caregiver, team leaders, educators, and researchers. So as you can see, nurses have to fill a lot of very important roles. And in conclusion, let me tell you, this is a say from Florence Nightingale that we celebrate her 200-year birth anniversary this year, the year of the nurse, and for nursing now. And she said, unless we are making progress in our nursing every year, every month, every week, take my word for it, we are going back. So I want to congratulate you for your efforts of moving forward, building home care in Japan for your amazing population, and I am wishing you all the best and a very productive conference. Thank you.
次はアメリカ・ワシントン大学の元学部長のマーラ・サーモン先生です。現在は同大学の看護とグローバルヘルスの教授、公共政策とガバナンスを担当されています。サーモン先生は医療政策と能力開発のためのグローバル人材育成、女性のエンパワーメントに精力を注がれ、近年は看護師及び助産師の起業家を通じた医療システムや医療サービスの強化に関する研究を行っておられます。今日は看護師、助産師、事業への投資がどのような効果が期待されているのか、その可能性について世界的なお話をいただきます。
Thank you very much for this honor to be here. It is my great pleasure, and I love having the connection with Japan and the nurses of Japan, and especially with this opportunity to celebrate the Year of the Nurse and to recognize the great honor it is to be working with the Sasakawa Foundation and also with the Japanese Nurses Association. And I want to particularly recognize and express my appreciation for Dr. Etsuko Kita, who is not only a dear friend, but has transformed nursing around the world and in Japan. And her vision takes us a long ways into the future. And it's my pleasure to be a part of the discussions of where that will go in the future. So thank you very much for this pleasure and this honor. So the focus of my topic today is on the empowerment of women and strengthening health systems, with a particular interest in what contributions there are that nurses and midwives can make through their development and their engagement in enterprise. So let me be more specific about what we can do for this session this afternoon. The first is I'm going to talk about the work that has been done that is leading to today and what it is that's our platform for discussion of nursing and midwifery enterprise. And the second is actually delving into that topic and to the landscape and all of those contextual forces that are a part of shaping the future of nursing and midwifery enterprise. And then last, my hope is that this will set the stage for a very rich discussion. And given who is attending this conference, I think that there are a lot of very important experiences that will be discussed, as well as perspectives. So the overall aims of this discussion and the project itself are to focus on improving women's lives and strengthening health systems and services. And one would think that that's pretty much what we are all about as nurses, and those of us who are nurses and also midwives. The rationale for caring about this, for focusing on it, is it's the key to the ongoing development of nursing, women's well-being, and human well-being. In other words, we're at a pivotal moment that we're needing to look at how we can continue to improve health and how we can continue to develop nursing and midwifery to make a difference in the world. The global backdrop, what is happening around us, is almost unprecedented. If you think carefully about the health challenges we're facing, and of course, COVID is in all of our minds as we think about it, but COVID is one of what we will see in the future, many communicable diseases. And part of what we're dealing with as well is our changing demographics, not only in terms of some groups and societies aging, but also some countries experiencing demographics of young waves of people coming in. And then we see migration and immigration challenges and opportunities around the world. We also are facing the economic realities of what COVID is driving and what will come in the future. It's important that we as nurses and midwives do not forget what is happening in terms of our climate-driven disasters and the inequities and poverty that we're experiencing. There's a lot going on that shapes opportunity for us to make impact. And we see that globally because there's a growing reliance on nurses and midwives to try to cast ways of affording, making accessible, and having effective services. In addition, we see some driving of change in the health system from investors, individuals, philanthropy, and governments who are investing in innovative approaches to actually making better health options available. One of the most important opportunities that we have is there's convergence of gender and occupation when it comes to nurses and midwives. If we can improve the working lot for nurses and midwives, we can also improve the well-being of women because so many of them are women. So let's talk about the terrain. What is the landscape out there that's shaping nursing and midwifery enterprise? Basically, there are 4 sectors involved, and one of them is the economic and social development sector. When we think about international aid, that's part of the development sector. Investment in growing economies, that's part of development. And in the past, for the last several decades, women have been identified as a target for investment, for creating enterprise that's women-owned and women-operated. But those investments are going to largely the agricultural and the commercial sectors. Not much has really gone yet to the health-related sector. Although I have to say what is happening in Japan and the community health centers are wonderful that the Sasakawa Foundation is funding. And that's one great example of philanthropy investing in an important solution. So the health sector has a long history as well, increasingly, of empowering women through service delivery. What this means is that the health sector has been providing services to women to try to ensure that they are healthier, that they have healthier childbirths. And so that's been an important factor in improving the well-being and the empowerment of women. But unfortunately, those same investments aren't taking place as much as they should in terms of the women who work in health systems. So investing in their well-being, investing in what they can do to own and operate their own enterprises. And then we have nursing and midwifery in general, and that's empowering women through the services that we provide, our organizations, our collective action, how we volunteer, and nursing and midwifery actually as a career opportunity for women. But lastly is this whole investment sector and the increasing investment globally in investors investing in rapidly and creatively growing health opportunities and innovation. So enterprise is growing, it's being invested in. Now, if you look at this schematically, here's the terrain. And what we're talking about for nursing and midwifery enterprise sits in the smack middle of 4 different sectors. So we see that nursing really can, and midwifery really can, take advantage of the opportunities that sit in those sectors and the forces that are shaping it. But this means that we need to think about what we're doing. So let's talk about work that's leading up to today. It comes from the field. Those of us who have worked globally know that nurses and midwives are doing remarkable things out there. We also know that many of the things that they're doing are things that are run by other people. Who knows best about nursing and midwifery work? It's nurses. How can we change the fact that they don't often own or operate their own enterprises? And that's where the research in nursing and midwifery enterprise comes in. And that research is research that we have undertaken with the Center for Health Market Innovations. And it was a landscaping study that we looked at, finding as much as we could about nursing and midwifery enterprise and women's empowerment. The project that we did looked at 1,237 documented projects that were in a database of projects globally from 129 countries, and there were 9 other sources of information. We ended up with 94 programs that we looked at, and what we found was that many of those programs focused on services to women, empowering women through services. But it was very unusual for them to focus on empowering the women who were working in those programs. So the irony was that we found a lot of programs that were providing and empowering services, providing services and empowering women, but we really didn't often find those that also empowered the women who were in those programs working, the nurses, the midwives, and others. Here's a bit of a map representation of where we found those programs and what they were. 46 of those programs focused on nurses, 25 on midwives, and 23 on both. They were all around the world. The most prominent were in India, Kenya, Tanzania, Uganda. And these were all lower income countries. And I want to stress here that we see some of the most innovation taking place in those countries. And we don't completely understand it, but we believe it's because of the great need and also the willingness to try innovative solutions that aren't necessarily restricted by some of the restrictions that we see in some of the more economically advantaged countries. The interesting thing about the programs that we saw was that many and most were focused on maternal and child health, some on primary care and some on both. So you see that we have examples in some cases of focusing on more than one. But the challenging pieces of this was that we saw very little focused on mental health, nutrition, dentistry, some of the things that are so important to the well-being of people, particularly if you're looking at some of the older populations. But these were the focuses, and we have a lot to learn from those as we go forward. But what did we learn? And these are lessons in a sense that represent the potential of what we learned. There's much more work to be done. But what we can draw from this is that there's great potential for nursing and midwifery enterprise to enhance both the reach and the impact of health systems. Nurses and midwives often are in places where no one else is in terms of healthcare providers, and they are naturals in terms of providing services. So that reach and also the absolute effectiveness of their services makes a huge difference. We found too that there were valuable opportunities for women and girls, not only within nursing, but that nurses and midwives could be wonderful models for helping women and girls in their development, and that these nursing centers and midwifery centers, regardless of what population they serve, could be community hubs and have spokes that reached out to engage and empower beyond the actual services that those nurses and midwives provided. We saw tremendous ownership and employment opportunities for women and for nurses and midwives, including staff and community health workers. And I want to make a comment here about community health workers, because often community health workers don't have the support and the frameworks within which to grow in practice as health professionals and perhaps even become nurses and midwives. So it provides career ladders and it provides opportunities for them to continue to learn and develop. Great potential for leadership development opportunities, not only from the perspective of management and administrative opportunities, but also within communities. And this is really reflected in the last one, which is we saw that when a nurse or a midwife owned and operated their own enterprises, they were often engaged in other things in the community, civic engagement, and societal standing. So they occupy places in their communities of leadership in many cases. So these are the potentials that can come out of the enterprise arena and how they strengthen nursing and midwifery, but also empower women and strengthen health services. As I say, there's much more research to do, but there's much promise. There are challenges. There are reasons why there are not a great number of these kinds of programs around the world. So we found within the models that there were things that could be done to actually enhance the possibility and the likelihood of nursing and midwifery enterprises. First is to learn the models and learn about the models that seem to help to foster the development of these development of these enterprises. We found that collective enterprises, networks of more than one enterprise, one clinic, one service center, that those networks were essential. They could be social franchises, they could be co-ops, or just networks. And sometimes they provided financing, sometimes they provided just the support around good quality care. And they're actually quite important. And so for sustainability, health impact, and empowerment, looking to social franchises, co-ops, and networks, bringing providers and their enterprises together. We also found that it is crucial that there's leadership and business training available. It's crucial that we have the kinds of leadership and business training, and that it is crucial that it happen. So these are ways to overcome challenge. There has to be investment and supportive and incubation, startup kinds of resources and ways to scale these enterprises to a point where they are sustainable. And there's a whole area of investment, social investment, that has emerged that's called gender lens investment, which is focused on investors, social impact investors, putting their money into women-owned, women-operated, women-benefiting businesses. And so gender lens investment in the social investment sector is one that's very promising. We also found that we need to rely on developing new partnerships and approaches that reach across sectors. Those 4 sectors that I mentioned in the terrain, it's important that nurses and midwives become comfortable with and engage actively in the conduct of partnership development across those boundaries. You won't be seeing much investment without connecting with investors. You won't be seeing much in terms of kinds of things that health services at systems level can do to support without working across those boundaries. So adopting these promising global lessons and models is going to be very important if we create different futures than what we have now. We have to learn more, we have to adopt, we have to try things out, we have to learn from one another. One of the biggest challenges that we see is having an environment, a legal and social environment in which there is support for women-owned and operated businesses in general, but also nursing and midwifery-owned, operated enterprise. So to do this, we really need the activism and the wisdom of a variety of partners, the legal sector, for instance, but also our nursing organizations and our educational institutes, and our investors need to help us develop these legal frameworks, policies, contracting frameworks, sources of financing and regulatory frameworks and partnerships that allow these enterprises to be developed, to be safely sustained, to offer quality services, and to be aligned with national and local health systems. And I want to say something particular about that. Many countries have national health systems, they have national health plans, and nursing and midwifery enterprise needs to be understood as a tremendous resource to those national health systems and plans achieving their objectives. So our hope is that as we develop these enterprises, that there are ways for them to be understood as key means for operationalizing the goals and the aspirations of those governments and their national health systems and plans. So it is also important that when we talk about partnerships, that we actually involve the partners in these activities. Sometimes when we do things as nurses, we will launch something and we might ask partners to be involved in helping support it, or we might ask partners to collaborate at the onset, but sometimes we don't see the importance of engaging them as full partners throughout the process. And without that partnership, we won't be doing all that we can do, but we also won't last as long as we should. And I also think it's important that when nurses and midwives own or operate their own enterprises, that they see their responsibility as also being the advancement of the well-being of their team members. Again, health systems have failed in empowering women within their employers. So employees need to have the support and the career opportunities and the development that is available to those who own and operate. This is about women's empowerment and ultimately about health. Again, I have to reiterate that we need to continue research. This is a global area of work, and there's lots going on that's worth looking at and worth sharing. And one of the exciting things about this conference is that this is probably the first real focus in the depth that is happening. So you're on the front end of really important development for the future. And I guess since I've been talking about the future, let me go back to the past and the present, because there's one thing that shouldn't change, and I hope it never changes, which is that for us to succeed, we need to continue to be who we are as nurses, as midwives, as health professionals, and as members of a global citizenship, which is we need to continue our commitment. We need to have courage. This is not easy work. We need to collaborate as we've known how to do. We need to communicate in the ways that were so effective. And we need to be creative, but most of all, we need to continue to care, because care and compassion is at the center of all of the work that we do and so much of what we need to do in the future. So with that, I'm going to thank you all, and just to say that there are some reports, and I will provide that information. It'll be available to you. There are reports. There are resources that can further give you information on this, and ultimately, thank you for what you do, and thank you for what you will do in the future.
最後はカナダ、マックス・マクタ大学副学長で健康科学看護学科長でもありますアンドレア・バーマン先生です。主な研究はエビデンスに基づく看護人材に関する政策や実践について研究をされています。最も精力を注がれているのは移民大国であるカナダで最も大きな女性の専門家グループである国際看護師たちの雇用に関してです。また、バーマン先生は故日野原重明先生との長い年のお付き合いがあり、日野原重明のリーダーシップ論という本を出版されています。今日はカナダと日本両国を知るバーマン先生より看護の価値の測定に関してお話しいただきます。
So again, thank you. And what I decided to really talk about is really fundamental. As you can see from my title, and some of you in the audience all know, or you'll know me, I am at McMaster, and I am involved in research, and we focus on nursing and nursing workforce issues. And our biggest concern is, of course, care, and nurses being at the forefront and the true caregivers within the healthcare system. And we wanted to talk today a little bit about measuring the value of nursing. This has been an ongoing challenge for the last few years in terms of trying to really prove empirically the value of nursing, and I think many nursing researchers have done that, and clinicians. But the struggle is not over yet. I think that in some areas we have deficiencies of nursing services around the world, and we need to support those nurses in making the argument for more nurses and better care. So my presentation will focus on that. So in preparing for this presentation, and again, reemphasizing the point, how long the nursing profession has been in existence. In fact, historically, we can see even further back than that. We can see the evolution of nursing services in the 14th century in what is now known as the Middle East. It was a different constellation of, I guess, almost empires during those times. But it's a very, very old profession. But I just put this slide in to reinforce in Canada and in Japan, really nursing became more formalized in the 1800s, sort of the later 1800s. And if you look in Japan, 1869, look in Canada, 1864. But in fact, again, like I was saying, the very first nursing endeavor in Canada, we can trace that all the way back to the Grey Nuns and trace it all the way back to the 16th century. So it's an old profession. It's growing and changing, and the roles are changing. I'm going to talk a little bit about that today. But again, nursing has an impact. It just, again, continues to struggle to have enough resources to continually maintain that impact. So we have established for quite some time that nursing is really the backbone of a healthcare system. In any country, there are many nurses. In Japan, there's over 1 million nurses. In Canada, there's close to 500,000 nurses. And large, in America, even more. And other countries, again, the same. Importantly, an area where nurses do a lot of service is in the care of our elderly and our vulnerable. So not everyone who's vulnerable is elderly, but our societies are getting older, and this is continually talked about. So the care of our elderly really has to become tantamount to the integrity of our society. And again, this statistic, 2018 in Japan, 28%, and expected to represent 30%. This was often discussed for a long time around the world, Japan's aging population. But guess what? Now the Western world's catching up, and they don't talk about it so much. They now begin to focus on themselves. So in 2020, 18% of our population is 65. But of course, this is going to grow. Now, one of Canada's solutions has been immigration, because we've got to somehow replenish our population, and our birth rate is low. In modern societies, that seems to be the trend as women become more educated, more independent, and also societies change. Societies become very expensive. People just make lots of decisions about families and starting families. But Canada is in a special situation where they have to bring in migration from all over the world in order. We have a very large country, and we know if we don't do this, that we'll soon be in a bit of a crisis around human resources. So next slide, please. It sort of shows you the landmass of Canada, and our population is not anywhere nearly as large as Japan. However, even more importantly, it's very dispersed. So we have a very large geographic area. The good part is our nursing to a certain extent, our nursing education, our regulatory bodies across the country are fairly well integrated. We don't have to have common curriculums, but we have much in common in nursing. So our associations, our regulatory bodies, even though it's provincial, i.e. prefecture centered, there's very good dialogue between these regulatory bodies. But this just gives you a snapshot of our population growth, and you can see it's not overly impressive. So there's probably going to be issues. So the issue of care is really important, and there are differences in the healthcare models between Japan and Canada and between many countries in the world. However, countries have similarities in the way they view the care function and how it's viewed and how it's valued. If you look in Canada, and if they do it survey after survey, when they're asked, the Canadian public's asked, who do you trust more? And they'll give a variety of healthcare services, healthcare positions. Nurses always come out as very highly respected and highly trusted. So people are aware of the care functions. However, public perceptions about care, not nurses, but care, has changed over time due to structural changes. So again, how it's organized is important, because nursing services are only as good as the way the services are organized. And this has come to be something we're all reflecting on. The need for nurses is increasing. There's no doubt about that, the importance of nurses. But global shortages make it challenging for countries, especially now, to fill gaps in the healthcare labor market. So this is a very, very busy slide, and Dr. Shamian may have inserted some examples, and I'm sure she'll talk about the state of the world's nursing. This was very important for us as a document. It came out WHO this year. It's important for a variety of reasons, and again, I'm sure Dr. Shamian, country comparisons. And so for nurses that are interested looking at international comparators, this document is invaluable. And nursing leaders in country, if they're discussing nursing human resources. And so one page covers a lot. And again, this is a very busy slide. I put it in about Canada, and I don't have a lot of time to dwell on these slides, but they are wonderful. It's a wonderful piece of work, and I gave the citation at the end. It's available on the web, and I'm encouraging everyone, if they haven't read it, it's an excellent resource to get a snapshot of nursing. So picking up on what we've said before, is nurses are on the forefront, and many nurses that we've seen today, and we will be talking about today, they are on the forefront of battling the epidemic. There's a significant disease burden as a result. About 10 years ago, we had an issue of infections in hospital, and my research group became very interested in that. And because we had to take extraordinary isolation procedures to battle the infections within hospitals, tracking the daily infection rate, etc. And it added to the workload of nurses at that time. And now it's been expanded to include management of the diseases. The nurses in the Canadian study estimated that IPAC, the donning and doffing as they call it, that are mandated for personal protective equipment, added 20 minutes to 2 hours to their shifts. I just want to show you this slide. It's a very busy slide again. So this was done by Alicia Kaba, a graduate student of mine. And because we were interested in really analyzing what infection added to the daily complexities of the nursing workload. And as I said, we did this a few years back. But what these circles show you, we picked a patient or a prototype of a patient who would be quite ill. And we tried to demonstrate the number of nursing procedures one would have to do and the management of patient daily care and the type of clinical decisions, and then superimpose infection on top of it. So when we say nurses are stressed during the epidemic, this diagram demonstrates the additional workload. And this diagram does not really recognize, nor are we able to really depict the psychological stress of all this. We have published this article, so it is available. And as I said, it was written before the epidemic. And so the epidemic really has added an additional burden to nurses' work. So it's really important that we begin to improve our understanding of complex problems. We also obtain information by not only encouraging but empowering frontline staff to share their insights and views. And I think this is ever more important given the context of what we're going through now. The frontline staff, as you could see in the previous diagram, really are trying their best to provide care. I'm pleased to say that actually we were looking at the absenteeism rate. The absenteeism rate, because of the epidemic, of course, if you have to be absent due to being quarantined yourself, you have to be absent. But those that are not are going to work every day and really trying hard to provide care because they know how critical it is. The second point really says we really have to all work together. And I think the epidemic has taught us that. And in long-term care, they talk about that, how they realize how interdependent they are with other services and how they have to lean on other services, i.e. the services of the hospital, the services of the military, the services of the Red Cross. So what you begin to see during crisis is a much more codependent approach. People do recognize they need others. This is not something one profession can do. And nurses are very good at that. They've always had strength in making teams work together. It's been one of the hallmarks of nursing services. We also have worked closely in developing a common language to increase interprofessional collaboration and enhance problem solving. So it goes a long way with mutual respect. If teams, work together closely, they respect each other. Pandemics are a very bad thing, and it's nothing anyone would want, but sometimes what comes out of it is a greater understanding of our mutual dependency and the need to work closely with each other. So they work across the spectrum, as I said, in Canada, and true in Japan. Actually, I have a really great PhD thesis in my office. Mariko Koyama did it, and she demonstrated the work in rehabilitation. And that's a very interesting study she did some time ago. But again, it showed the issue of transdisciplinarity and what facilitates it and what are some of the barriers. Nursing practice changes when there are critical events, and the slide before really demonstrates that. When you have an overriding infection and all the reverse isolation, you're not only doing your care of your patient, you're trying to care for the families. Now, these families may not be able to visit their loved ones, so there's great stories about how nurses and doctors too trying to maintain contact with families somehow, either by electronic or by phone, to try to keep the families involved. Teamwork is essential, and I can't say that much in the studies we're doing, in the interviews of these homes, looking at what works. The leaders and the nurses, dietary, cleaning services, they all talk about teamwork. But the last point is important. It's leadership in crisis is paramount. People look to leaders to give them guidance and to keep that team unified. It does put an even greater pressure on leadership to be innovative and to really stay close to their staff and try to stay as close as they can to the patients or the clients, but really stay close to the staff, because it's the staff where they're looking to the leaders to keep them going. So what have we learned in Canada? We've learned the pandemic has had a significant impact on the ability to care. We also now see we're heading for an acute shortage of personnel, and care workers have emerged. Previous to this, the focus was on the cure function, again, the technology, the physicians, rather than the care. Acute care systems were well staffed, but the community care and the care of the vulnerable are now in crisis mode in Canada. So again, measuring the value of nursing is really important. They're on the interface. The databases are important to identify nurses. Data and metrics are vital for understanding and responding to changes affecting the cost of delivery of care. I want to just spend a few seconds on this third point. When the World Health did that important piece on nursing, measuring nursing in some countries was very difficult, partly because we don't really have a standardized definition for nursing, and that does get in the way of sometimes recognizing nursing services in some countries. So the workforce analytics really are the set of data analysis tool and metrics that we have to have for comprehensive workforce planning and measurement and improvement. I'm just putting this up. I'm not going to dwell on it, but nursing is defined differently around the world. And in some countries, the definitions are quite comprehensive and followed up by ways of describing what nurses do. And I put Japan and Canada's definitions, but it's not true of all countries. And I know in a big World Bank study we critiqued, they were talking about health services and they didn't even include nursing. They include physician services that got a lot of attention. Nursing was nowhere. And they said, this is the very definition. We cannot, there's no standardized definition. This was in the Americas, Latin America, and North and Central America. So the future of caring, COVID exists and it shows us our weaknesses. We have unanticipated consequences, putting further strain on social and health systems. Our vulnerable population, increased risk, and now we've exacerbated yet again a shortage of healthcare professionals. Caring is more complex and nurses are at the forefront. So we need to focus on merging the roles and models to support the delivery of care. So the latest evidence, the nursing workforce is expanding in size and scope and importance. However, it's still insufficient to meet the rising demand. We know now there's excellent nursing studies to show that the investment in nurses contribute to health-related SDG targets: education, gender, decent work, and economic growth. Those are only 3 examples where the nursing profession plays a really important role. So Dr. Shamian's presentation will emphasizes this, but we need to invest in accelerating nursing education. Now, Japan did this. We all remember the green paper when you could see the changing demographics and the expansion of the nursing schools. And I really applaud that. That did not happen in Canada, and I still think that was a gold standard way of preparing for the future. Forecasting is showing, again, need many, many new nurses by 2013 all around the world. Focus is on countries that have very poor nursing services, but in order to give to others, we need to have strong nursing services within our own country. And we need to strengthen nursing leaders. It's imperative that nurses are engaged in and have the power to influence policies and decisions. I'm just going to end with a message from Dr. Hanahara. As you know, I had the privilege of working on a book with Dr. Hanahara because I had observed him many years ago. And those of you who know him, you know he was really a strong supporter of nursing. And he really had some very wise lessons for us all. And I still find today his words very inspirational, and I can hear them in my mind. The one thing I remember him saying is, life seldom proceeds in a straight line. And this we found to be true this year for sure. The ability to review a situation and provide direction becomes even more important in crisis. And then he was referring to a leader there. He talked closely, which should inspire us all, about the role of adversity, because he himself had adversity in his young life. The real issue is focused specifically on how to address the challenges that present themselves, and more importantly, how to rise above them. And finally, he talked a lot about courage and perseverance. And he talked about innovation should be encouraged, changes should be initiated, and new ideas should be advanced. So final thoughts. In Japan, Canada, and other countries worldwide, nurses are working together to provide care under extraordinary circumstances, and they are sustaining health systems that are being challenged by COVID. Based on his experiences, Dr. Hanahara understood that in a crisis, particularly one with severe impact and outcomes, people have to walk together like mountain climbers who are bound to one another by a rope. In the hands of nurses, this rope is a lifeline. Thank you very much.
続いて仲間3人の発表です。最初は在宅看護ネットワーク第1号の干拓を福島市で開業した沼崎光子氏です。干拓の仕組みと実際について発表します。
ただいまご紹介に預かりました一般財団法人脳神経疾患研究所看護小規模多機能型居宅介護事業所在宅看護センター結野学校所長の沼崎光子です。どうぞよろしくお願いいたします。我が国は少子高齢化多子社会に突入し、同時に多様なニーズに応えられる看護が期待されています。地域包括ケアシステムが進む中において、これからの看護師は今まで医師のそばで働いていたのが当たり前であったのが、これからは医師のいないところで働かなくてはならなくなり、看護師自身が病気を知る力とその人を丸ごと見る地域看護師が求められる時代になります。地域で安心して暮らせる社会づくりを看護師が中心となり支える仕組みが必要であると考え始めたのが訪問看護や看取り経験の後に医療施設の看護管理についている時でした。昨今社会的孤立などにより地域でのつながりが弱まり生活上困難なケースが増えてきています。よって高齢者や障害を持つ人たちを地域で支え合い皆があらゆる場面において地域で安心して暮らせる仕組みを確立するための地域共生社会への転換が必要と考えます。特に医療ニーズの高い方が地域で生活を継続していくには地域を知っている医療・福祉の専門職の連携が不可欠ですが、縦割り制度の中でシームレスな支援体制を進めることは極めて困難であり、かなりのエネルギーを要します。馴染みのスタッフの存在下で柔軟に組み合わせ可能な干多機の活用は利便性があり、利用者、家族ともに安心感が得られます。点から面で在宅療養生活を支え、在宅の限界点を高められることも実践からの手応えであります。さらに、介護保険法、医療保険法、児童福祉法、障害者総合支援法を網羅したサービスを提供できるのも干多機の醍醐味と言えます。次に、干多機の概要について簡単に説明をいたします。干多機は病気を抱えていても医療と介護の両面で最後まで支える介護保険制度です。平成24年に複合型サービス事業として制度化され、平成27年度に干多機に改称されました。病態変動時や家族の介護疲れ、医療施設から在宅移行期の受け皿など、医療ニーズの高い人々に24時間365日の在宅療養支援ができます。訪問看護、介護、泊まり、通い、相談の多方面な機能を持ち備えたサービスで、登録人員の上限は29人、通いは1日18人まで、泊まりは9人までとなります。訪問看護ステーションと併設することで、干多機登録者以外のニーズにも対応でき、 短期入所のみも可能となります。当事業所は看護の登録人数範囲内で基準該当サービス事業も展開しており、医療的ケアの必要な障害者、障害児の受け入れも行っております。在宅看護センター優位の学校の実際です。これは福島県の地図になりますけれども、2019年度の高齢化率は全国 28.1% に対し、福島県 30.9%、福島市 29.0% で、福島市の人口は約28万人で中核都市になります。当事業所の清水地区の高齢化率はやや低く 27.3% で、世帯数が多く、若い世帯も住みやすい場所になっております。運営体制はスライドの通りで、看護、基準該当、訪問看護、居宅介護支援の事業を一体的に行っています。それにより幅広な地域カバー力が可能となり、さらには経営的にも安定できております。当事業所の取り組みです。各関係機関との連携は、訪問看護と看護利用者の一元管理を行いつつ、医療機関の主治医、矯正、居宅や施設の介護支援専門員、さらには障害者相談支援専門員と柔軟に積極的に連絡を取ります。特に医療機関との連携を密にすることで、安易な救急車要請を避けることができております。地域のかかりつけ看護師として、活躍をさせていただいているところであります。2016年から2019年の看取りの割合は、自宅が 42%、医療施設が 30%、看護が 29% で、在宅看取り扱いは 70% という低い数値でした。これには看護師が中心となり、介護士や多職種連共同の下で、利用者ご家族の不安に寄り添い、家族にとって大切な人の最後をどうしたいかを一緒に考え、意思決定支援を都度行い、例えば泊まったり通ったり家にいたりの中で、だんだん呼吸が弱くなり最後が近づいてきたことを介護者と共有し、大切な人への最後を後悔しないよう思いを確認しながら、辛い時期に泊まりを多く組み込むなど、プランをその都度柔軟に変更し、本当に最後を迎えるときに自宅へ戻すことができたケースが多かったことであります。この仕組みは社会保障費の削減にも寄与できると考えております。事例紹介になります。この方は起用はたくさんありましたが、要介護後の老衰で亡くなりました。当初は経口摂取困難により CV ポートが増設され、当訪問看護ステーションを利用し、持続点滴管理を行っていました。担当ケアマネから看護登録の提案があり、2年2ヶ月の登録期間を看護と自宅の行き来をしました。長男との2人暮らしで夜勤専従の仕事をしている息子さんに合わせ、泊まり、通い、訪問のプランを組みました。しかし、いつも母親といる生活は息子が息が詰まるとのことで、本人とも話し合い、お互い一人で夜を過ごす日もプランニングしました。登録するまではほとんどが家のベッド上の生活だったため、送迎中に四季折々の景色を楽しんだり、イベントなどをとても楽しんでいました。馴染みのスタッフの関わりで、一時は食事が口から食べれるようになり、点滴も中止し、会話や編み物など生きがいをも見出せるようになりました。息子さんも母が喜んで看護を利用してくれるから安心して仕事に打ち込むことができると言って、介護と仕事の両立ができました。しかし、徐々に食べる量が減り、点滴を再開する時期が来ました。再度寝たきりとなり、腰に節が見られたため、主治医と息子さんと話し合いの場を持ち、最後は苦しませたくないとのことで徐々に点滴を減量していきました。家で看取りたいと息子さんは意思決定し、職場に休みを希望しましたが、思うようにいかず休暇を取る最後の夜勤の朝方、看護で最後を迎えました。息子さんに連絡すると、一人夜勤なのですぐには行けないとのことで、夜勤を全うしてから駆けつけてくれました。これでよかった。俺一人で看取ると言ったけど、やっぱりパニックになっていたと思う。母は大好きな結の学校でみんなに看取ってほしかったんだと思う。と穏やかな母の顔に声をかけてくれました。そして出勤した職員全員でお見送りをし、自宅へお帰りになりました。 カンタキは馴染みのスタッフの存在下に泊まり通い、訪問介護を柔軟に組み合わせることができるため、昼夜の状態を家族と共有でき、症状悪化や家族の心情などの状況把握が容易になります。さらに、看取り機の利用者に限らず、家族ともに緊密に関われるためのアプローチもしやすくなります。主治医との連携を密に行うことで、最終段階が近いことを適切な時期に把握できるため、本人と家族が最終期をどこでどのように過ごしたいかの意思決定支援のための時間が持てます。不安なく住み慣れた住居で最後の日々を暮らせることへの支援の中で、一番本人、家族が辛いことはスピリチュアルペイン、霊的苦悩であり、お亡くなりになる1、2週間前あたりにほとんどの方が体験します。病院に入院しているとボンという言葉になり、薬で抑えられてしまいがちですが、苦悩に寄り添い、死を覚悟するまで支援をすることで、看取りのタイミングを適切に設定し得ることができると考えます。在宅看護センター結の学校の役割と展望についてですが、自宅、医療施設、介護施設、行政との医療ニーズに対応できる地域連携はもちろんのこと、クラフトたちよりきちんと安心のたまり場として、病院だけでも施設だけでもない結の学校はもう一つの自宅というイメージで、保健、看護、介護、セラピスト、栄養管理、事務のタスクシェアのもとに、ご近所、経済活動、社会活動などコミュニティの中から地域住民同士で支え合う社会づくりのハブ役として、社会の変化に敏腕に対応できる地域包括的医療マネジメントにおける看護の多機能化について見据えていくことであると考えます。これからの地域看護の役割は地域社会へ参入すべきであると考えます。地域の中でその人がいつもの暮らしを最後まで安心して生きられることへの支えを行い、疾患や障害を持った方々も生活者であるということを踏まえ、日常生活の視点から専門的に関わり、そして家族看護の視点からも地域住民の健康の質低下を予防する啓発も必要です。入退院支援や入退院調整機能を医師、看護師、介護職、多職種、異業種と連携を取りながら、地域社会を生まれる前から綾世代、高齢者、看取り後のグリーフケアまで一緒に支える仕組みを作っていく、すなわち地域共生社会の構築に積極的に関与する人材育成が重要になるであろうと考えます。以上で発表を終わります。ご清聴ありがとうございました。
兵庫県豊岡市のやや過疎化した農村地域でユニークな看護を経営している大月京子氏です。中山間地域における看護について発表します。
一般社団法人ソーシャルデザインリガレスでの大月京子です。本日は中山間地域における看護でお話をさせてもらいたいと思います。よろしくお願いします。私が住む兵庫県は日本でもやや西側に位置しまして、有名なところでは神戸市を持っている県なんですけれども、私が住むところはその神戸とは全く反対側の北側にある豊岡市というところに住んでいます。でこの地は、南に比べるとすごく人口が少なく、もう過疎地と言われ、いわゆる田舎と言われる状態の地域がたくさん点在しています。具体的に見ていきますと、例えば東京23区と照らし合わせてみたんですけれども、このように航空写真でも東京の方はもうほとんど街でぎっしり埋まってるんですけれども、私が住む豊岡市はもう山に囲まれ、そして谷のところに人が住んでいるというような状況で、訪問看護の状況でも谷に入り、また谷を戻り、また別の谷に入り、谷に戻り、そして冬は北側ですので、新潟の方と同じぐらいの雪が降る時期もあったりとか、すごくなかなか大変なことも多くあります。人口密度は、東京の23区と比べ100分の1と言われ、だいたい東京に100人人がいるところに1人しかいないようなイメージ、そんなところです。でどんどん街はやっぱり人口減少とともに空洞化していきまして、ぐっと人がいないところ、そして奥に入るとまたぽつりぽつりとあるような感じで、空き家がどんどん増えております。で病院や診療所は縮小し、地域の先生方も高齢化し、 この今年に入ってもですね、数カ所診療所が閉じたというようなことも起こっております。そんな中で山手にあります少し大きな古屋を改築して看宅と言われる事業に挑戦しました。少しこれリノベーションした後の外側なんですけれども、今ここの左側の前に古い建物が建ってるんですけど、それは今またレストランになって後で写真でも出てきます。看宅はこの奥側の黒い屋根のところを看護師小規模宅の看宅で、こんな感じで玄関からのアプローチで入ってすぐのリビングのところですね。もう木なんかは本当に150年前のままなんですけど、すごくいい素材でできたお家だったので、こうやって立派に再生されてます。書院。ここは客間だったんですけどね、一番いいお客様が来られるお部屋。ここも一つお部屋になっております。上の方の壁なんかもそのままになっております。建物の周りにはもう本当にたくさん緑や畑、山がありますので、こちらの方のご利用者様はもともと畑をされてた方も多くって、またその暮らしを戻していくという意味で周囲にある土地を活用して農業をしたり、右下の方は庭の中に大きな栗の木がありますので、季節になったら今まで皆さんがされてたように栗を拾ってその栗を炊いて栗ご飯をみんなで食べてそれを分け合ってというようなことをしたり、子供が少ない地域なんでなかなか子供がたくさん寄る仕組みっていうのは難しくって、スタッフの子供さんを連れてきてくださってハロウィンのイベントをしたり、そういうような感じで人々が暮らしを崩さない状況をここでも作って看護をしていくっていうことをしております。で、特に一番大事にしているのはやっぱり食べるっていうケアをとても大事にしてまして、現在 ST さんも在籍しておりまして、今ここでお写真に写られている方も病院では一旦寝たきりだった方がもう9割ぐらいです。実は少しずつ皆さんでもう一口でも食べれるよねっていうところを、看護師がきちんとフィジカルアセスメントもしながら ST さんのマッサージをしてもらって、それをみんなで習得して食べれる形態のものから始めて、最後はしっかり食べれるようになるっていうところ、そしてやっぱりイベントを起こすことで食がすごく華やかになるので、普段食欲がない方でも食べるというきっかけになるということで、極力天気のいい日は中庭を持っている事業所ですので、中庭に出て日に当たって、みんなで晴れのような時間ですね、ちょっとお弁当にして食べたりっていう、そういうことをとても大事にしております。で、そうすることで点滴で水分を取っていた方とか経過栄養をやっていた方っていうことが口からもう一度食べれるようになるっていうことが起こっております。終了時の状況なんですけれども、これは2020年の10月までの状況になります。で、やっぱり約8割の方は最後まで、うちのサービスの中で看取りをさせてもらっていて、実際施設の中での看取りと、サービスの中で一旦家に帰られた時にですね、家族の中で看取りをしている。で、あととても症状が改善して介護度がすごく軽くなって他のサービスに行かれたり、介護度がなくなった方もおられたりするんですけれども、他のサービスへということですね。10% 程度が再入院されているというのが現状です。先ほど言っていた手前のですね、古い建物の方を今再生しまして、食べることを大切にするっていうことの引き続きでオーガニックのレストランを運営しております。で、こちらの方はもう本当に一般の方のお客様を対象としておりまして、ご高齢の方とか日常カフェとかではなく一般のレストランとして運用してます。で、たまにご利用者さんのご家族さんがちょっと家族でお誕生日会しますとか、そういったことも使ってもらったりもしますけれども、地域はすごく人口減少をしていきますので、そこのところの地域全体の活性化っていうことも同時に考えないと、福祉そのものがすごく厳しい町ということになっておりますので、そういった仕掛けも同時に考えて動いております。そんな中で私は地域に出て看護が機能していく、どう機能していくことで、より地域が健康になっていくのかっていうことを考えたときに、やっぱり看護師はすごく観察力を持っているので、 その鋭い観察力で地域を見る、で見て考察する、でその中でその考察した中で街を作っていく意識を持った看護師が増えていくと、どんどんと人々の暮らしが豊かになっていくんじゃないかなっていうような今気づきをいただいてます。で、多くの看護師がこういったことで街づくりの意識を持って地域に出てくるっていうことが今後すごく望ましいんじゃないかなというふうに感じております。地域看護を継続して頑張っていきたいなと思っております。よろしくお願いします。
都市部で訪問看護ステーションを運営する磯野優子氏です。高齢化が進む日本ですが、地域によって様々な課題があり、看護師が担う地域ケアについて発表します。
一般社団法人コークリエーション地域まるごとケアステーション川崎、磯野優子と申します。よろしくお願いいたします。私たちの仕事は訪問看護師です。看護師がお宅に訪問し、病気や障害に応じた看護を行い、自宅で再起を迎えたいという希望に沿った看護、アドバンスケアプランニングなどを主治医の指示を受けて病院と同じようなケアを行っております。訪問看護はどんなことをしてくれるのかと申しますと、健康状態の観察や病気の悪化防止、リハビリテーションなど主治医の指示に応じて緊急時の対応など多職種と連携しながら訪問看護を行っています。訪問看護を起業しようと思ったとき、どうして私は地域まるごとケアステーションにしようかと思ったことをお話ししたいと思います。地域まるごとケアという言葉に出会い、地域まるごとケアとは私が考えたのではなく、先駆的な地域医療、介護を実践されてきた諸先輩方が考えられ、老いや病を支えるために医療・介護の連携と地域コミュニティの中で支え合い、うまくつながり合うこと、仕組みではなく地域の人たちと時間をかけて作り上げていくもの、地域包括ケアよりもさらに広いつながりということを私は知り、地域まるごとケアを訪問看護で実践したいと思うようになりました。これは超高齢社会のニーズの特徴です。後期高齢者の方は介護、慢性疾患が多く、急性期医療をほとんど使用せず、本人の暮らし、人生に合わせた多数の慢性疾患や老いとの調和、生活支援、そして役割や社会参加などを必要と要しています。それによって命の尊厳を守る地域、コミュニティケアが必要だと思いました。私は川崎市で起業しています。私の住んでいる川崎市幸区では、このような人口構造になっています。こちらは高齢者 75% の割合を示した図で、赤い濃いところが高齢化率の高いところです。こちらは子どもの15歳未満の人口割合を示した図で、濃い青いところが子どもの人口割合が 20% 以上のところです。このように高齢者が多い地域と子どもが多い地域とかがあり、地域格差を生じています。高齢者だけではなく子どもなどすべての人の地域で暮らすさまざまな人の健康を看護の視点で見ていこうと考えました。訪問看護から地域ケアへ、ケアの視点で地域を見る。私たちは普通の訪問看護と地域福祉を融合させて地域資源の人、物、こと、場を活用し、地域の社会参加につなげ、地域マネジメントを行いながらケアを携わっていきました。それはつまり、普通の訪問看護の個別ケアから本人を中心としたコミュニティ、地域ケアの展開をしていくということです。動物公園や直売野菜のコミュニティを使った活動参加型のリハビリテーションや、そういった自然や文化を使いながらケアを展開し、地域で生きることを支援しています。そして大都市の健康課題にケアでチャレンジしています。急性期専門病院が多く、利用者は複数科を受診しています。その結果、以下のようにポリファーマシーや本人に適切なケアが行われていなかったり、 地域や暮らしの中でのケアが医療に偏っているのではないかと思いました。地域での継続ケアをするためには、私たち看護や多職種だけではなく、本人のコミュニティや文化を使ったケアを生かし、統合ケアマネジメントを実践しています。そしてその中でも、このような引きこもり、生きづらさを抱える人たちの支援があります。生きづらさを抱えた人たちは、なかなかケア介入が難しく、そこに至るまで時間がかかります。そしてその地域福祉に移行したりするときに、そのつなぐ役割が私はいないと感じ、つなぎ役として私たちがボランティアで時間を作り、例えば中年期の引きこもりの方には、その方が自転車に乗ってみたいとおっしゃったので、自転車に乗る練習を行い、有償ボランティアにつなげていくことができました。また他の引きこもりの方はステーションに通い、就労支援をする中でお弁当を作って地域の方にお弁当を届けていけるまでになりました。訪問中に自転車に乗ってちょっと気になる方やホームレスの方に挨拶をして、その挨拶の中から関係性を作り、台風やコロナのウイルスの時にも声をかけ、支援をすることができました。また制度にはありませんが、子育て支援にもチャレンジしています。地域の中で子どもが多い地域でしたので、お子さんの相談を受けることが多く、保育園の地域子育て支援事業のボランティアに行きました。今回のコロナウイルスのパンデミックの時には、地域の子育て中のお母さんから子どもの遊び場がないということや、思いっきり遊べないという相談を受け、このように保健師と共同しながら子どもたちのプールや照明流しなど、そういった母子保健に力を入れ、感染予防だけではなく、地域につながりと希望と癒しの力をつけたいと思い、写真家の方に相談をし、様々な催しをすることができました。辛さや悲しさ、楽しさなど、自由に表現できるまちづくりをしたいと思っています。私たちが目指すもの、それは地域の中で共に暮らし、ゆるいつながりです。こちらの横断幕をご覧ください。この横断幕は4月に子育て中のスタッフが子どもたちと相談をして、これを掲げてくださいというふうに言われ、一人じゃないよ、相談してねという横断幕を掲げました。それに対して地域住民の方がこのような母の日にオブジェをマンションの下に作ってくださいました。どなたが作ってくださったのか分かりませんが、この子どもたちの思いが地域の方にも通じているんだと思い、私は感動しました。一人一人が人生の主役として生きるために、自ら持てる力や暮らしを地域の中で発揮できるつながりや思いやりがある街だと私は思います。子どもたちにとって有事の際にも安心して暮らせる社会であるよう、地域住民主体の地域丸ごとケアを広げていきたいと思います。そして地域で暮らす住民の一人として、看護師として、誇りと生涯継続できる仕事としての価値を作り、サイエンスアートである看護を探求し続けていきたいと思います。私たちが目指す誰人も取り残さない保健医療、地域共生社会の実現に向けたまちづくりを、これからも地域の方たちと一緒にクリエーションしながら、ケアで地域の未来を育んでいきたいと思います。
次は、これまでに発表したメンバー全員で、これからの看護についてディスカッションを行います。
Andrea and Mara, do you have any comment on the presentation by Japanese?
And I actually have two kinds of comments to make. One of them is back to Atsuko's introduction of herself. And what she didn't say was that she's responsible for sponsoring and supporting and advancing nursing in so many different ways. So you occupy a special place in nursing, even though you're not a nurse. So I wanted to acknowledge that. And it's always an honor to be with you. The second thing is that I thought that the presentations really demonstrated the major themes that I think are part of what is common among each of these programs. And one of those themes is a deep commitment to serving the community and a profound connection with what nursing can do and a commitment to advancing nursing's capacity. A third dimension, though, I would mention quite sincerely, is that these are powerful women who are doing this work. And I have such respect because this isn't easy work, and you've been able to do remarkable achievements. And the platform that the Sasakawa Foundation has provided for developing that leadership component and the skills is quite impressive. So those themes of being leader, committed nurse, and someone who cares about the community deeply are very evident across those examples.
I remember when Dr. Kita talked about the program at the beginning of the program, and I also had an opportunity to present to one of the classes that were going through the program, with how you took the concept, the idea, the learning, and took it to practice. And I'm also very impressed how nurses becoming entrepreneurs in managing their own practice and providing the leadership. What we have been able to do in Canada, while you develop the concept of home care, you also develop the social care and really looking after the whole community in a very integrated, supportive way. It's shown in an OECD report that came out 2 weeks ago. The life expectancy in Japan is growing, as we know that you have excellent life expectancy, but it's growing. So the support and the programs that you're putting in place hopefully will be scaled up across your country, and all seniors and those that need the support could benefit from it.
Andrea and Mara, do you want to add more comment to in addition to Judith?
I would like to build on something that Judith mentioned, and it's really nice to see you. It's great having you. And that is this whole interest in the economic side of this. And I noticed, Itsuko, that you're really at a very critical moment, and it relates to how we can transition all of these enterprises from that startup, which is so magnificent, the training and the preparation and the network development that's happened, to scaling these enterprises to the point where they're sustainable, and also where they are replicable by others. And one of the powers that I see in this group now is that you are a collective in addition to being individuals. And by being collective, by being connected in a network as you are, it's a very strong thing and can potentially be used in the future for everything from quality assurance kinds of connections, training, even finance. So I just wanted to add that, because this critical moment that you're at, you've accomplished so much. It's a critical, important moment, and you have in place the platform, as Judith mentions, from the amount of development that's taken place from that original vision to where it is now, to take it to the next step. And it's critical for this world that we have what you offer.
How about Andrea?
I guess, one of the further questions I had, with COVID, there's been a real problem of isolation and loneliness, and people in their homes, and people being alone. And the very vulnerable populations. And I was wondering, again, these centers seem so organized. What type of services are they offering, or how are you able to continue to offer service in these difficult times where people are alone and it's very hard to reach them? So I just wondered if there was any observations or what you're doing about that. Because I know in Canada we have services, but we're not very well organized in terms of the community sector the way your centers came across.
声をかけてました。訪問中に自転車で回るので挨拶をしたり話をしていました。でそこにたまたま、コロナが入ったのでそのコロナのことを伝えてます。台風の時は台風だから早く逃げた方がいいよとかその日は家から出ないでっていうふうに話してました。で今やってることは私たちだけじゃいけないと思ったのでコンビニの店員さんやお店の店員さんたちにその困ってる人とかその支援がつながらない人たちにニックネームをつけているのでその人たちを気になるんだみたいな話を地域の人たちにしたら地域の人も気になっていたっていうことを言ってその見守りの輪が広がってきたように思います。
About that, which is that the partnerships that are evident in these that aren't necessarily partnerships with healthcare providers at all are so important. And that was a theme that I saw throughout here was reaching across these professional boundaries, not being stuck in talking to only nurses, working only with nurses, is working outside and using every resource that's possible. And that's very impressive.
My comment following up to Marla's comment about partnership, I think the whole program is an exemplar for partnership because while I know that the Japanese Nursing Association was a partner, without Dr. Kita and the Nippon Foundation, this would have not happened. And I think we don't have too many examples where we see global foundation that focuses on specific home care or nursing agenda and puts in the resources and the efforts to make that happen. So I think that level of partnership is extremely crucial. And the one thing I would say is that I believe that the time has come, Dr. Kita, for the collective you to put out a book, not just in Japanese, but in English also, because I think there are a lot of lessons that many of us can learn from what you have done.
私、これをちょっと、すごい皆さんよりも、すごいショートな時間で、どんなものなのかっていうのを自分で把握したんですけども、皆さんのこの、このお三方のを見て、これから世界がCOVID でコロナのところでここにこのシャミヤさんも緊急事態と有事の対応っていうのが新しい看護師の役割っていうことで課題に挙げてらして、アンドレアさんですね。アンドレアさんの最後のところに、その日野原先生が有事の際、特に甚大な影響と結果を伴う危機状態に関してこのような言葉を残しているって危機的状況下にいるとき、私たちヤロープで一つにつなぎになる登山家たちのように協力し合わなければならないって書いてらっしゃるんですね。で、だから今この時に、ちょっとこのセッションとはちょっとあれなんで、かけ離れてるかもしれないですけども、この世界の看護師が、一人一人が、手をつないで、このパンデミックな、世界に、立ち向かっていけれるような、そういう、なんていうのかな、使命っていうか、持っていければいいなと思います。私自体も、ナイチンゲールを読んで、 このナイチンゲールみたいに光の手を差し伸べる人になりたいと思って看護師になったので、ナースたちが一人で立ち向かってるんじゃないと言っていけたらいいなと思います。全然関係ないんだけど、これだけは伝えたいと思います。ありがとうございます。
Thank you very much. Yes, in my opinion, I am not very arrogant to dominate to nursing society, but I think nursing is a universal humanitarian science. So I believe in this unstable world, only nursing can contribute to any person in any place, any country, either rich or poor. We need to keep health, and nursing is the only tool for people for them to keep their health. So I hope not only Japanese nurses, but also global nurses can make very close communication to promote health, not only the individual health, but also health of the community, health of the country, health of the world. So that is the reason why I opened this big project. But fortunately, with Dr. Julie Sabian, Dr. Andrea Bowman, Dr. Bala Salmon, we have very big supporter to our project, in my opinion. So I hope in future we can expand our activity, not only in Japan, but also in many countries. That is my conclusion, Sabian.